Well, good morning, everyone, and welcome to our presentation this morning. I want to introduce our guest, Dr. Maryam Lustberg. Dr. Lustberg is the director for the Center of Breast Cancer at Smilow Cancer Hospital and Yale Cancer Center, where she is the chief of breast medical oncology at Yale. Dr. Lustberg is going to enlighten us on some of the side effect solutions, specifically for men with breast cancer. As we well know, some of you gentlemen suffer a little bit more than the females. So, Dr. Lustberg, I welcome you to our presentation today.
Thank you so much, Sherry, and thank you for all of you who have joined. And I aim to finish with leaving enough time for questions and conversation. And I really do see these sessions as an opportunity for me to learn from you and what is working for you and not working for you, as well as sharing kind of what I have learned as a breast oncologist. Um, there's lots of toxicities and lots of side effects. These are the few that we will touch on today, and certainly things that are not covered on this list, happy to also discuss after I finish the talk portion of the talk. So kind of one of the challenges, as you all know, of male breast cancer is that there is a lot of extrapolation and not a lot of data, and things are improving. I think we're doing a lot more focused studies, and certainly the clinical trials have thankfully become more inclusive. But I think kind of what you'll hear in this presentation is a lot of the data gaps, because a lot of the toxicity management data that we have are either from females with breast cancer, and then there's a lot of extrapolation from bladder and prostate cancer as well. So the point is not to equate the experience of male breast cancer with any of these, but just highlighting the data gaps that we have while we strive to generate more data. The presentation is not about therapeutics specifically, but this space is rapidly changing, where we have a lot of targeted therapies that I will not be specifically focusing on. However, generally we are extrapolating from the existing data in female breast cancer. And if you have specific questions about some of these targeted therapies, happy to discuss those. Tamoxifen does remain the mainstay currently for hormone receptor positive breast cancer, for both for males, and I'll be spending a lot of time talking about the toxicities related to that. First, kind of what are our data showing? Again, your individual experience is your individual experience, and often is not able to be perfectly captured in a lot of these surveys. One, a lot of these surveys were not validated in male breast cancer. So we're taking some prostate cancer subscales and taking some female breast cancer subscales. So they're limited as we kind of look at these outcomes. But sharing with you here some data on quality of life from EORTC 185, which is a prospective registry of quality of life in male breast cancer. And kind of, the takeaway is that in general, the patients that were in these studies, part of this registry, generally had kind of comparing both males and females, had how we define good is again subjective, but you can see that physical function was comparable, kind of between males and females. Emotional functioning was a little bit better compared to females. Cognitive functioning about the same. Global health status compared to the normative male population may be slightly reduced, but kind of, at least in these types of survey assessments, maybe slightly better than the female population, but lots of symptoms. And again, I think the story that I will tell, and I'm sure many of you have experienced, is that there is a lot of unmet burden of toxicity in the population that perhaps has not been fully captured. So kind of again, we're seeing high rates of fatigue being reported. And kind of financial difficulties have made it come up, have been flagged in multiple surveys as cancer treatments has become more expensive. In terms of, arm symptoms, particularly after axillary dissection, this is a concern that was picked up by this survey. Hair loss, we'll spend some time talking about this, where hair loss concerns have been often minimized in the male breast cancer population, but they continue to come up in multiple surveys. And we'll spend some time talking about sexual activity concerns as well as hormonal symptoms that are coming up. Part of kind of the limitations of survey instruments is it's who you ask and who actually fills out your survey. So I think there's often a lot of bias in a lot of these registry surveys where maybe the more fit patients are more likely to participate and more likely to answer these questions. So the general population may look more well than actually what we see in the real world. This was more of a real world type of sample with its own limitations, but it included 127 male patients with breast cancer. And the type of reach out was through social media surveys. So again, the population is one who is on social media, but it was a global survey. And these are some of the concerns that were really kind of coming up: hot flashes, impact on sexual interest, hair loss again, lymphedema issues and shoulder issues, particularly after lymphedema surgery, and pain in the chest wall scars after surgical recovery. So kind of high numbers of patients, more than half the participants actually were reporting pain in the chest wall area, and we'll spend some time talking about that. 61% were bothered by hair issues, and 78% were reporting impact on sexual interest. And kind of further kind of delving into, in the same survey, physical symptoms, peripheral neuropathy, which I'm not going to spend too much time talking about, but this is a research interest of mine, and I'm happy to get questions on that or any other area. But lots of fatigue, lots of pain, and sexual concerns, and kind of self-consciousness about appearance comes up for some patients. Fear of recurrence. This has emerged. Fear of cancer recurrence has been recognized as an entity within itself, and kind of how we are relaying information about recurrence risk, how we're talking about these in busy oncology visits. I think that this continues to come up as a concern. So we're going to kind of focus on a few of these areas. Hot flashes. Typically in the male breast cancer setting, it would be in response to tamoxifen or gonadal suppression in combination with an aromatase inhibitor. Most often it's going to be tamoxifen. And a lot of our data is from females, although there were a few key studies in other cancers in terms of vasomotor symptoms or hot flashes. Most of the data in males is in prostate cancer. But just kind of talking about one of the interesting things about symptom management studies is that the power of our mind. So kind of there is actually a moderate placebo effect. So if we're taking something that we think might be helping our symptoms, we can actually see a modest improvement in symptoms. Megestrol, kind of a progesterone-based therapy where there is actually also data in prostate cancer in males and hot flashes, is one of our most effective regimens. Venlafaxine, we have data in as an antidepressant. It's a common agent that we often use in both male and female breast cancer with hot flashes. Many of our antidepressants like citalopram have been shown to be beneficial. Pregabalin brand name Lyrica, and gabapentin have also been shown. So as you can see, there's been a lot of repurposing of agents for management of hot flashes. Clonidine used to, as a blood pressure agent, used to be used more, but as you can see, its effect is much more modest than some of these other agents. I'll be showing you data on oxybutynin, which is one of our newer agents for hot flashes. It is repurposed overactive bladder agent. We have data in males now in prostate cancer. So this is one area of data. There's also been a lot of negative studies in hot flashes. I know many of my patients ask about different supplements that may help hot flashes, and as you can see, these are no better than placebo. So tend to have very low effect. So if the hot flashes are bothersome enough that are keeping you up at night and disturbing your day, I think pharmacologic interventions, whether it be our antidepressants or oxybutynin, which I will show you the data on now, are some of our go-to indications that we use routinely in clinic now. This was a study of hot flashes in men. And again, my apologies, I'm not equating prostate cancer to male breast cancer, but this is one of our larger studies that we have in the experience of vasomotor symptoms in males and androgen deprivation therapy, and whether kind of oxybutynin, which was shown to be helpful in females, could be helpful in males. And this was presented in the ASCO 2024 meeting. As I mentioned, it's a it's an overactive bladder agent. But was shown in a randomized control study to be quite beneficial in women who were experiencing hot flashes, and then this led to this follow-up study. It included placebo as well as the usual starting dose in overactive bladder at 5 milligram per PID, but also a lower dose of 2.5 milligram BID. And these were men who were experiencing quite a bit of hot flashes, averaging at least 28 hot flashes per week. And we wanted to see what effect oxybutynin had. And as you can see here, again, there's a little bit of a placebo effect because our minds are powerful. But most of the effect was seen in the 2.5 as well as the 5 milligram BID dose. A little bit more of a hot flash reduction when the 5 milligram BID dose. This is kind of showing you percent change in hot flash frequency based on the arm, placebo here, where again, initially, when we're taking a medication, we're excited about it, we're pumped up, we're like, yay, this could be really helpful for me. And then it sort of levels out, whereas kind of, especially with the 5 milligram BID, you can see that the improvement in hot flashes continues. And looking at the percentage of patients that are at least having a 50% reduction in hot flash scores, you can see that close to almost 60% at the 2.5 milligrams and almost 80% at 5 milligram BID. There's no free drug financially or physically, so there's always side effects, as you all know. In general, though, most serious adverse events tended to be low. And the most common things that patients report on oxybutynin is actually dry mouth. So this is the common thing that I counsel my patients about when I talk about this drug. There's a small risk of urinary retention, a lot of urinary symptoms because it's an overactive bladder agent. So if you don't have an overactive bladder and are taking this agent, this can be an issue. But in general, the most common thing is dry mouth, and overall don't want to learned from patients to not ever call something tolerable because the experience is individual to each patient. So you will decide if this is tolerable for you. But in general, on average, patients did not have serious adverse events. So this is one of our tools. There's not going to be a follow-up male breast cancer study, but this is just going to be one of our tools where if I'm seeing a male breast cancer patient in clinic who's having a lot of hot flashes, I think this is going to be one of the tools that I have in addition to gabapentin, in addition to the antidepressants. And we spend time typically talking about the pros and cons, as well as the different side effect profiles of each agent. And patients often choose, they have often very strong feelings about where they want to start. Insurance does get in the mix as well, because sometimes we're mandated by insurance in terms of what order of agents that we use. And this is particularly true with the new hot flash medications that I will present next. As I was telling the story of hot flashes, as I mentioned, a lot of these are repurposed medications. They were not specific drugs for hot flashes. And basically, the experience of hot flashes is actually central in our brain. And there's been elegant work over the last decade really showing that there are these candy neurons in our brain that actually help us thermoregulate and set our temperature stores in our body. And kind of with drugs like tamoxifen or gonadal suppression injections that we use, this balance becomes shifted, these exquisite control mechanisms actually get disrupted, and this actually presents as kind of the experience of vasomotor symptoms, the hotness, the flashes, the sweating, all that has a very precise mechanism that has been identified, and now we actually have drugs that can block this step. And by doing so, we can essentially stop biologically the experience of hot flashes. And so, again, back to extrapolating, my apologies, but this was done in postmenopausal women without a history of breast cancer who were experiencing hot flashes. And this was the first neurokinin receptor antagonist drug that's currently approved in the US, showing about a 50 to 60% reduction in hot flashes. And this led to the FDA approval of this drug last May. It's quite expensive, so we're kind of facing restrictions. We are launching a breast cancer study in females to further show whether in response to endocrine therapy, this agent is still quite effective. Right now, none of the data are in cancer for this agent, but there is a study in development to specifically look at this in males. So people are thinking about kind of additional data generation in the cancer population. There is a second agent that was just presented 2 months ago in ASCO, and same idea, kind of blocking this receptor pathway. And this one was in females with history of breast cancer, and it was a placebo-controlled trial. And again, compared to placebo, this had a much more significant reduction in hot flashes. And this is not currently FDA approved in the US. It is approved in Europe and Canada currently. The FDA is considering the case of this agent in terms of what registration and approval may look like. And again, multiple folks are looking at how they can further study this in males. So I do anticipate more data coming. Again, no free drug. So there was kind of about 9 to 10% of patients had inexplicably more fatigue and somnolence with this agent, and this neurokinin receptor pathway blocker, a little bit of diarrhea. In general, the majority of patients did not have serious adverse events. So more data to come on these agents, but I wanted to, again, make sure that I had shared with you the 2 agents that are in the horizon, share with you the oxybutynin data, which is ready to be used now If you're miserable with vasomotor symptoms and hot flashes, know that there are solutions out there, and you can kind of work typically with your oncologist and possibly your primary care, but generally oncologists are managing these symptoms. So we can take questions at the end. Moving on to body image, I think this is something that as a community of oncologists, we have perhaps not spent a lot of time talking or acknowledging the experience of males with this issue. Interested to know your experience at the end, but there has been kind of a minimization of what this experience of breast cancer means to males, and that's what that's at least what the data and the literature are showing, and that we've kind of said, oh, you're fine, but essentially what the experience and the data are showing is that there is quite a bit of impact from these breast cancer treatments on body image, including the impact of chest wall surgery, the stigma of breast cancer itself, lymphedema issues, weight gain due to tamoxifen. I'll cover that in a little bit. And there's been a number of qualitative studies that have directly taken transcripts of the words of male breast cancer patients to kind of catalog what they're reporting. So you can see here kind of these particular individuals feeling very self-conscious about the appearance of the chest wall, maybe choosing to cover their chest and kind of in the beach or pool area. This was an Italian study by Mancino and colleagues that was just read out in 2024. About a third of the male breast cancer survivors having concerns about chest wall appearance. And also, in addition, I wanted to highlight here kind of not necessarily feeling comfortable communicating their needs to their clinical teams, and kind of holding it in and being stoic about it is what this survey showed. Kind of moving on to hair, and I'll briefly touch on neuropathy here. In the last 15 years, we've had quite a bit of advances in terms of cooling the scalp as a way of preserving hair, particularly during taxane chemotherapy, which is a common chemo agent that we use in male or female breast cancer. And so there are multiple ways of delivering scalp cooling, including portable devices where patient is kind of shifting out and changing the cap every 15 minutes. And then there are more devices that an infusion center may have so that the coolant is continuously circulating, so you don't have to be constantly changing your cap. And then in most recent years, we also have data that from phase 2 studies that at the same time cooling the hands and feet may also reduce the chance of neuropathy. And so there's now a phase 3 study looking at cryocompression for reduction of neuropathy in breast cancer patients. But the question that had come up is how many males are even being given the opportunity to learn about scalp cooling, or are people assuming that they're males and they don't care about hair? And so this was a large University of Michigan study that was published in 2022, looking at kind of different factors that influence the decision of doing scalp cooling. And one factor that emerged is that being male, you were less likely to do scalp cooling. And I think complex factors in terms of whether you were offered or not offered, and you can kind of see a higher proportion of males that were potentially eligible for undergoing scalp cooling did not do scalp cooling. And the study did not include a qualitative component to really understand from the patient experience why they didn't. But lots of other factors were identified as influencing the decision to do scalp cooling or not. Financial health, because in many states, other than New York, actually, scalp cooling is not officially covered by insurance, although there's a lot of advocacy going on for that. And so I think there's complex socio-demographic factors, but I do think kind of from other qualitative work, I think there is also an underlying assumption that, oh, males are not bothered by this. Why even offer it as a choice? So this is something that I think is an opportunity for additional advocacy and education. Moving on to sexual dysfunction, a lot of our data, unfortunately, are from prostate cancer and bladder cancer, but there have been some new data that I will share with you. The key culprits tend to be tamoxifen, gonadal suppression with tamoxifen or aromatase inhibitor tend to have even a greater sexual function effect. There may be indirect effects with chemotherapy and targeted therapies that are not haven't been directly studied in that way. Most of our data is with endocrine therapy. And then certainly having breast cancer does not preclude you for having other complications that any male without a history of cancer may experience that may impact sexual function. So I think it's this potpourri of different contributors that can impact sexual function. Our oldest study is from 2012. This was at the time one of the larger studies where the experience of tamoxifen in males was specifically studied in about over 100 patients. And this did not include metastatic patients, and they absolutely need to be included in these survivorship studies. This included stage 1 to 3 patients and essentially cataloged what type of toxicities they were reporting on tamoxifen. Weight gain and sexual dysfunction and loss of libido was being reported by 22% of patients, followed by hot flashes at 13%, and then all of these are important, so this is not me minimizing them, but these tended to be a little bit less reported. In terms of what led to the discontinuation of therapy, thromboembolic events were one of the key reasons, followed by loss of libido. So again, as a breast oncologist, you know, this is me speaking to my colleagues, is that we have to have these conversations. It's not just coming in for tamoxifen and say, you're taking your pill, have a good day. I think there are profound impacts on quality of life that actually impact the ability to be able to persist on therapy, which then impacts disease outcomes. So these are very much on the oncologist and the patient to have open communication. And what I've learned over the years is if I don't ask, sometimes patients don't feel like it's safe to bring up this issue and they don't report it. So kind of making it a safe environment to report these symptoms is important. Next, I'll show you a more recent survey that was read out in 2024. It's a smaller survey, but kind of captures maybe the experience of more modern times in terms of these agents. Included 36 male patients with breast cancer, and median age was 62. The second bullet probably does not surprise you, and I think Sherry has been working very hard in terms of improving awareness and knowledge about male breast cancer, as others have as well. But only 27% of patients prior to their diagnosis were even aware that male breast cancer was possible. In this survey, 2/3 were on endocrine therapy, mostly tamoxifen. And many experienced changes in their sexual activity while they were going through acute treatment. So when they're going through surgery, radiation, on all those, almost half the patients reported changes in their sexual activity. Just again, highlighting that there is a lot of gaps. So what to do about it? One, we need to talk about it openly and kind of take out the discomfort of addressing these in oncology visit. Unfortunately, a lot of our intervention data does not exist in male breast cancer, and again is extrapolation from prostate cancer world. And so the number one intervention tends to be these PDE5 inhibitors for erectile dysfunction, and there's a number of agents to choose from. And I have here kind of the duration. Kind of they can be used as needed, on demand, or daily dosing, particularly with tadalafil, where it had a longer half-life. And so in prostate world, they have been shown to improve function, both after surgery and radiation. We don't have good data on male breast cancer, but anecdotally, yes, these could be an option that could be used, and really having a holistic look and holistic discussions with the help of sexual health counselors, and really including the partner, addressing expectations, and really also not forgetting kind of other non-pharmacological interventions, like kind of focusing on lifestyle and stress reduction, which can also impact the sexual experience after cancer. There are other strategies, but again, little data in male breast cancer, but there is a vacuum-assisted erection device. There is intracavernosal injection of vasoactive drugs that could be used. There is intraurethral suppositories that could be used, and surgically implanted penile prostheses. So all of them have different pros and cons, and I think they're very much individual decisions, also insurance coverage. And so these are different options. None of them are 100% perfect, and none of them work 100% of the time. But again, we need to be able to openly talk about these and discuss all these options with our patients. A question that comes up is, you're telling me tamoxifen is the most common culprit. Well, what else can you do about tamoxifen? So this is a little bit of an off-label discussion. Again, I am not suggesting that anybody run out here and do low-dose tamoxifen, but it's my duty to tell you that there are now data on low-dose tamoxifen at 5 milligrams. And what we see is that there was an Italian study. This study would never initially get done in the US. There was an Italian study in females where 5 milligrams was compared to placebo in patients at high risk for breast cancer. And what they found was that tamoxifen was highly effective at 5 milligrams. Normally, we use the 20 milligram dose. So at 5 milligrams in this high-risk population, this was quite effective. So this has actually become the standard of care in females at high risk for breast cancer, particularly postmenopausal females. We're using the 5 milligrams as one of our options for risk reduction. And as things happen in breast cancer, anytime there's an indication in one area, then we ask the question, can we expand the indication to another area? So now there's a phase 3 study called the LOTAM study in low-risk invasive breast cancer in females, and in postmenopausal females, that's currently accruing nationally. And I will share that there was concern about including men, not because we wanted to be exclusionary, but premenopausal women were also excluded, because when this original Italian data, when the data were cut, the biggest benefit was seen in the postmenopausal individuals, whereas the effect seemed to not be as great in premenopausal. So the concern is that if a male with tamoxifen alone, without the GnRH agonist suppressing the gonadal secretion of hormones, it may not be enough. So so I think in this particular case, a lot of thought went to this. So which is the reason for the exclusion, although I know that that may still be bothersome to some of you that this is indeed happening. In my practice, I do have a discussion with my patient. If the choice is coming off tamoxifen 20 milligrams altogether due to sexual function issues or other concerns, if the choice is not being on anything versus being on 5 milligrams, it's a choice that I have, and I really explain and document and have detailed discussions that we don't have good data. But this is a choice that I do offer. And just anecdotally, when patients are having sexual function deficits on 20 milligrams, it tends to improve on the 5 milligrams. So just wanted to kind of put that out there. Again, discuss it with your oncologist. We do not have official data in 5 milligrams in male, but just wanted to let you know that this was happening in this phase 3 study in postmenopausal females. Then the next few chapters will be shorter, so we have time to talk. So fatigue is reported by a number of male breast cancer survivors, and the data that we have is extrapolating from other populations. We do not have a good study of intervention in male breast cancer, but the principles are screen for it, make sure to report it if it's affecting you. Look at other contributors, meaning we want to rule out low hemoglobin, we want to rule out thyroid issues. Know that fatigue looks different in different individuals. It may be, there's actually 5 different trajectories of cancer-related fatigue that have been identified. That's a talk in its own. There are patients where they kind of peak right after treatment and then they continue to improve. There are patients where they continue to stay very elevated throughout. If you're on ongoing therapy, particularly in the metastatic stage 4 male breast cancer setting, I think having a conversation about modification of the targeted therapy dose is something that we're really talking quite a bit about. Cannot emphasize enough the value of oncological rehab, physical therapy, and regular physical activity. I wish I could say there is a pill that works here, but these non-pharmacological interventions, stretching, yoga, mindfulness, taking a walk when you feel exhausted, even for 5 to 10 minutes, have been shown to be most beneficial. And just kind of again highlighting again that this in male breast cancer surveys, this is really being flagged as a huge area of unmet need. And then wrapping up with metabolic health, which could be a talk of its own as well. And so back in 2018, what kind of entered our map of thinking about heart health as well as breast health. As you can see, this is very much tailored to females. So wait for the next slide. But essentially what was kind of put out by the American Heart Association is that breast cancer and cardiovascular health actually can have a lot of shared risk factors. And as we take care of breast cancer survivors, it's a necessity for us to be thinking about cardiometabolic health. One, because it impacts survival, but also that as we address cardiac risk factors, in essence, we're also addressing the breast cancer risk factors. So really kind of really emphasizing the synergy between the two. Thankfully, in 2024, a group in Spain actually specifically looked at male breast cancer and cardiometabolic risk factors. And as you can see, this was a large retrospective effort that was just published in Nature Scientific Reports. And they kind of compared, how, what was the proportion of male breast cancer patients that had, let's say, lipid issues, cholesterol issues. And as you can see, like, I'm sorry, it's cut off a little bit here, like compared to women, male breast cancer patients actually had very high proportion of lipid profile issues. Hypertension was about the same. Diabetes, again, this is not saying you are responsible for your cancer. I'm not saying that at all, but that there are comorbid conditions that can coexist. And by addressing those, we can also improve our cancer outcomes. Obesity and this is in Spain. So I imagine that if we did this data in the United States, the numbers would even be higher. So 16% of the male breast cancer patients had obesity issues. So I think the diabetes and the lipid metabolism really kind of come back to the idea of like metabolic health being an important thing that needs to be addressed as part of, and this is something that your oncologist can flag But we are not equipped to fully address these. So this is where partnership with primary care and a cardiologist really is key. This is a recent review that I did with my team. I'm sure you've all heard of the GLP-1 agents that are kind of all being discussed in multiple media sources. One of the questions that we had was, what are the safety data? Because the original GLP-1 agonists were not, they didn't include patients with a history of cancer. So pretty much we looked at the literature review for the last 10 years, looking at cell line data, animal models, and then any human data that we have. And there does not appear, based on this retrospective look, to be an adverse effect in breast cancer outcomes and GLP-1 agonists, and even some data that it might actually help. So again, not saying everybody should go and be on GLP-1 agonists, but it's again one of the many tools that we have in terms of improving cardiometabolic health. And so just putting it on the radar to have these discussions and really seeing them as a key component of optimization of survivorship care in male breast cancer or any other type of cancer. So just I want to make sure I have time for your questions. So I'm going to stop here. Thank you so much.
Thank you, Dr. Lustberg. We appreciate it. That was a wonderful presentation. And I'm going to open it up to everyone. If you could just use the raise your hand button, that would be very helpful. Or if you enter questions in the chat, I know we did get a couple of them. We have one gentleman, I know I've spoken to him before, and he's on tamoxifen, letrozole, and fulvestrant, and he's having a horrible time with phlegm. It's not coming from the sinus or from the lungs, but it's causing chest pressure and difficulty with breathing. Any suggestions there?
I'm sorry that you're going through this. Um, I don't know. I don't know is my honest answer. I think it sounds like a complicated picture of sometimes we know these therapies can aggravate allergies that would not have otherwise been there. So I'm curious if perhaps any of the kind of antihistamines or things like that have been tried, plus lots of hydration and humidification of the home environment would be kind of one of the things that I would explore, but I would maybe look at kind of potential allergies. I've definitely seen cancer treatments kind of uncover allergies that were not previously being explored.
Okay.
Question on Verzenio. Yes, so Verzenio is now approved. It's a CDK4/6 inhibitor, approved both in the metastatic first line or second setting, as well as high-risk breast cancer, defined as kind of node positive early stage breast cancer with high-risk features such as a tumor size 5 centimeter or greater, 1 to 3 positive nodes, grade 3, or four nodes or larger. So yes, the most common complaint on Verzenio is cancer-related fatigue. The recommendations for this is kind of discussing with your oncologist how bothersome these are. Dose reductions were done on the trials with Verzenio on over a third of patients, and it did not impact efficacy. So if you're having profound fatigue that's impacting your quality of life, feel free to open up the conversation with your oncologist and ask about dose reduction. Also, at the same time, make sure that other contributors like thyroid issues, anemia issues, kidney issues, all those things, which you're likely getting routine blood work anyway on Verzenio. But I would encourage an open conversation about dose reduction in addition to kind of regular rehab and walking and things like that.
Okay, Jim Tuffield?
Yeah, hi, Jim Tuffield here. I'm stage 4. I've been metastatic for 8 years. I've been on 23 different treatments, and I'm finally on a drug called Trodelvy. I started on it, and I ended up neutropenic and febrile, and ended up in the hospital for 4 days. And just now they're giving me a slightly lower dose and also giving me a follow-up day 2 and day 3 injections for white cells. But I'm really tired and I get very fatigued. I just wondered, is there anything that's been done to enhance bone marrow production of blood cells? Because it seems like mine's getting kind of beaten up.
Yeah, so for those of you who may not be familiar with Trodelvy, it's one of our newer classes of drugs known as antibody drug conjugates. It's a newer way of delivering chemotherapy. It attaches to a target on top of the cell called TRP2 and then internalizes into the cancer cell and releases the chemo drugs. Bone marrow suppression from the drug, so the new label actually is recommending a more liberal use of growth factor injections. So I'm glad that you're getting that. Regarding anemia, I think it depends on is your fatigue really coming from the anemia? And I think it's complex. Is it coming from the anemia? Is it coming from the cancer treatment or coming from something else? There is an EPO erythropoietin agents that we use occasionally for boosting hemoglobin, particularly if you're needing transfusions. But they do come at a cost, the cost being that sometimes they can increase thromboembolic events, and they have not officially been shown to improve long-term outcomes with cancer. So without knowing all your labs, I think it would be difficult for me to say whether, but I think discussing EPO agents or further dose reduction. For select patients, I do use sometimes low doses of dexamethasone. There was a study that showed just low doses of dexamethasone is a steroid pill, as you may know already, used intermittently can also improve the sense of well-being. Limited data on psychostimulants like Ritalin being helpful, but again, a case-by-case discussion for each patient.
And I'm also just want to add on, I'm always freezing. That's the other thing. I'm always cold. I'm wearing a long sleeve shirt. It's 75 in here. Is that a common?
Not the most common, but has your thyroid function been checked recently?
Yeah.
And it's not that.
Fine. Yeah.
Hard to say. It's
Okay.
not the most common thing.
All right. Thank you.
Sure.
I know what we see information out there about 45% of men drop out of taking tamoxifen because they can't handle these side effects. What are your suggestions with that? Again, is this, when you're feeling this way, have a conversation with your doctor rather than just stopping a treatment?
Yeah. So I think coming back to understanding your risk of recurrence, I think obviously even in this group, we have a wide range of stages of disease. And I think, the smallest stage 1 breast cancer is going to have obviously a different risk of recurrence than somebody with stage 3 disease. So if you have not specifically had that conversation with your doctor in terms of there are now risk calculators that can be used to estimate. So one, you need to know your risk so you can have a better understanding of what is the proposed benefit of tamoxifen and what is the risk of recurrence. Second, then the question is, are there side effects that could be potentially managed with other medications rather than stopping it? And three, if really the toxicities are just not acceptable to you, I think still having that conversation would be helpful. Maybe exploring that low dose tamoxifen again with the caveats that we don't have data. But I do think ultimately I do believe it's absolutely the patient choice, but I just want to make sure that the data are shared and that there's good understanding of kind of the pros and cons of stopping. I think about in 5 to 10% of patients, no matter what we do, I think that the toxicities are intolerable and not acceptable. But I think in the rest of the patients, I think with some tweaks and side effect management, I think we can get there. So not being afraid to bring up side effects would be my recommendation.
Okay. Bob Ritter, no questions from you. I know you're usually the one who's speaking up.
No, it's very helpful and very informative. So thank you.
Okay.
Can I ask you a question? No.
Sure, go ahead.
Yeah, can I ask you a question about letrozole and hand cramps and trigger finger?
Yes. Aromatase inhibitors as a class have been associated with trigger finger. It's not often recognized, so thank you for bringing it up. So aromatase inhibitors as a class can cause joint symptoms, trigger finger, also
Cramps.
carpal tunnel syndrome. So
Yeah.
I would certainly injections could be used, but I would be very cautious about doing surgery on these joints. Typically, I do a hold of the aromatase inhibitor for 4 to 6 weeks, if appropriate
Yeah.
for your particular stage,
Yeah.
and see what improves and what doesn't improves. Rotating to another aromatase inhibitor in the same class helps about 40% of the time. So you can even stay in the same class of drug, but rotating your drug can help.
Yeah, I was on also because obviously letrozole is with Amit. I can't pronounce it properly. Maxis.
Abemaciclib?
Yeah,
Venis-
that's
Yeah.
with it. But because I've come off letrozole, I can't have that one. And also I've come off Zoladex injection as well. And I'm just on tamoxifen,
Tamoxifen.
20
Okay.
milligram, 20 milligram for 2 months.
And how is it going? Are the joints feeling better?
They are feeling a bit better, and my thumb's starting to move again. The one that was seized up. I have trouble with my other hand as well. That's been sticky. But first thing in the morning, but I notice if I put them in hot water or cold water, it tends to relieve the symptom. Is that a thing?
We have phase 3 data for acupuncture for musculoskeletal symptoms of aromatase inhibitor, and our other phase 3 data is actually with duloxetine, but no perfect solutions. And there are definitely some patients like yourself that have to come off of the drug if it's being that
Yeah.
bothersome.
Going back to
Unfortunately.
going back to the tamoxifen, if I'm having the same, because I've researched it, and it does say that you still get hand cramps and trigger finger with tamoxifen. Could I decrease the dosage if that's a problem, or like you say, go on to a different inhibitor? Keep trying different inhibitors.
Yeah. So I think in a more advanced stage of disease, I would be worried about reducing the tamoxifen dose.
Mm,
If you have not tried fulvestrant or Faslodex, that is an estrogen receptor downgrader that we often use in the more locally advanced and advanced breast
yeah,
cancer setting. That tends to have the least joint symptoms. So if you're
right.
struggling with tamoxifen, perhaps looking into seeing whether your particular health system has coverage for that. Generally, it is covered, depending on where you are. So with fulvestrant, the other advantage for you is that it can be safely combined with abemaciclib. So if your doctor and you believe that targeted therapy is an important addition to your therapy right now, fulvestrant may give you the best of both worlds. One, you can get the targeted therapy, and two, it tends to have the least joint symptoms.
Yeah,
Do
the,
something to
the
talk about.
therapy that I'm on at the moment is just like a mop-up type thing because I've had the surgery and I've had the removal of the lymph nodes and everything like that, So I'm just thinking this is just a mop-up of everything
Yes.
that's
So
behind it,
you're
you know what I mean? To continue in case there's any microscopic anywhere else
okay.
in the body.
So
So
in the stage 3 setting, I think
yeah, it's only
um,
grade two it was listed as grade two. What was taken
okay.
out? Grade two.
Okay, so
So,
I think, and if you haven't had occupational therapy specifically for the hands, I think that can be sometimes helpful. But
yeah.
yes, I think what you're reporting is sometimes these joint symptoms can be quite bothersome, and we don't have good solutions for them. I think if the choice is not doing anything at all versus 5 milligram of tamoxifen is something to discuss. I do worry a little bit about 5 milligrams of tamoxifen in stage 3 disease. But again, if the choice is not doing anything at all versus something, I think 5
Yeah.
milligrams could be considered.
Dr. Lustberg, in some of these trials that you mentioned that were done specifically in women and that they are in the future or someone is looking at doing them in men, is that something that you can make me aware of so that I can share it out to everyone. Because what we found is a lot of times sending somebody to clinicaltrials.gov is just overwhelming. And seeing as this population is a smaller subset of breast cancer, by letting us know which trials are enrolling, the actual specifics, and how to get information on it. I know it's something that was helpful with the current trial for Ethan that's being run out of Dana-Farber. I actually spoke to Dr. Leone and he says, how can you help me? I said, you need to get me something that I can share with all of these men to give them the ability to get in touch with you. That's how you're going to bring more men into these studies, because
Yeah.
digging for it on their own and relying on their doctor, sadly, it's not going to happen.
I completely agree. Yeah, no, happy to kind of as things develop, happy to share them with you.
Okay. Any other questions, gentlemen?
There was a
Everyone.
question about changing the Verzenio dose. So the starting dose is 150 milligram twice a day. There is sometimes an approach to start at a lower dose and then titrate up if you're not having side effects. So the standard way of doing is you start at 150 milligram twice a day, and then you go down if you're having side effects. That's the on-label use. The off-label use is there was a study in ASCO this year called the TRADE study, where they started at a lower dose and then went up depending on tolerability. And the hypothesis was if we start out slowly, we might be able to get there. So if you're not having any side effects, I think going up is essentially what the TRADE study did that was presented in ASCO this year. So I think it depends. It depends on your side effects. What the data collectively show that the 100 milligram dose or even one dose level down seems to have similar efficacy, especially in patients who had initial toxicity on the higher dose.
Okay.
I'm the one who asked that question about that, and I
Yeah.
started at 100, and they want to put me up to 150. And the side effect, even at 100, is, I'm tired come 3, 4 o'clock every day. So I'm worried if I go up to 150, I'm going to be tired, more. I mean,
Yes.
I guess that's
You
Yes,
might
going to
not get
happen,
out of,
right?
you might not get out of bed in the morning.
Yeah, no,
Yeah, exactly.
so not knowing what your oncologist is specifically thinking about, but in my practice, if you're already experiencing toxicities on the 100, I would not be escalating the dose. Because
That's what I thought.
it will
Okay.
get worse.
All right. Thank you.
Bryce?
Yes, thank you. I was the one who asked the question about the phlegm, which is probably the most annoying thing, along with fatigue, which you've talked about. One of the side effects hormone therapy have had for me over the years is cramping, nighttime cramps in my legs, sometimes cramps if I turn my torso the wrong way along my side and along my back. For one brief year, I wasn't on hormone therapy and they disappeared. So I know it's connected to the endocrine therapy. And I'm just wondering, is there something you found? I mean, have you encountered this before? And if you have, is there something you found that helps reduce sort of cramps at night or cramps just during the day?
So I would make sure that your magnesium and phosphorus levels have been checked in the blood work recently. And even if the magnesium levels are normal, extra supplementation with mag citrate or mag oxide at night, it's a natural muscle relaxant. So that's something that I do find helpful for patients having muscle cramps on endocrine therapy. Massaging the area and stretching your calves and kind of your whole body right before bedtime is something that we do recommend. Applying some heat or a heated or weighted blanket can help with the calf symptoms. But if you have not explored magnesium, I would do that. That's typically our most natural therapy that we use. If you're just kind of achy overall and don't have a contraindication to taking anti-inflammatory medications, I think Voltaren gel, just kind of applying it to topically. It has very little systemic absorption, but kind of it's now over the counter. So Voltaren gel sometimes can be kind of extra anti-inflammatory support to some of the most bothersome areas.
Thank you.
Any other questions? Okay, James, unmute yourself.
Yeah.
There you go.
I lost power to my laptop. That's why I went off. Yeah, I
Okay.
don't know if Mary said anything else. If Maryam said anything else about the letrozole and stuff.
No, I think she was just answering some of the other questions.
Yeah, right.
But this whole session is recorded. Once
Okay.
I will have it available,
Yeah.
and send everyone the link so that
Yeah.
you can look back at anything to see if it has been missed.
Okay. Yeah.
And if there's,
I glossed over acupuncture. I know
Yes, you
depending
did.
on
Yeah.
where you are in the world, acupuncture can
New
have
England,
different
yes.
access issues. If you have not explored it and if it's available to you, we really have randomized good phase 3 data for acupuncture and joint symptoms. So
Okay.
it's something to definitely look at if it's not a financial hardship, because sometimes it's out of pocket or we don't have qualified practitioners. But I can't say enough good things in the hands of a good practitioner who is comfortable working with patients with cancer. That's one of our underutilized tools.
Can I ask you a question about testosterone levels in the body? When I've been on letrozole and the other one which you can't pronounce, that whatever it says some salt.
Abemaciclib.
Yeah, yeah, and there's Zoladex. When I spoke to the nurse, I had a pre blood test before that, and my level was 34. On the NHS, they say 27, but now my levels have gone to 0.06.
Since you started the suppression.
Yeah.
Yes.
So they're trying to get rid of all that and the estrogen as well. Estrogen levels 0 sort of thing.
So certainly good for the cancer,
Yeah.
in terms of, but certainly can be associated with additional side effects to have kind of those
Yeah.
hormonal levels being low like that. But
Yeah.
yes, it's a good
What
thing for the
would you
cancer.
what would you say is a normal level though with somebody with cancer? Is acceptable at testosterone levels, or are you thinking 0 as well?
I think less than 10.
Less than 10.
Yeah.
Yeah, yeah. But because obviously 0.06 is a really low level, isn't it?
Yes,
Which
yes.
could contribute to hot flushes and all that sort of thing. And
Yeah, it's just that
yeah,
we're not smart enough to dial it down or kind of have a dial. So typically
Yeah.
when you're using these gonadal suppression injections, I think they suppress differently depending on your individual makeup and things like
Yeah.
that. So I wish we could dial it, but
Yeah.
we are not smart enough yet.
No, okay. Thank you very much.
Mitchell? I just unmute.
Hi.
There you go.
In regards to cramping, I want to just share that I've had great success with pickle juice and yellow mustard, and it was my doctor told me to try that, and it worked incredibly quickly, like unbelievable. And my friend told me that his girls are on the UCLA volleyball team, and they use that as well. So I want to just let you know,
Yeah.
you were talking about cramping. It's really
They
good.
come in little shots.
Yes.
Oh.
Little shots, yeah.
I wasn't even aware of that. I just take
Yes,
the
yes,
pickles
yes.
jar with the pickles and drink it.
Yes, I've seen those as well. So lots of good electrolytes and salt. So that's the idea. Kind of repleting your sodium and mag and all those things. Yep.
And then may I ask, I just want to say, because I'm listening here, I take fulvestrant and Kisqali.
Mhm.
And how do you know if it's working? Because I was on the what was the first one you were mentioned? The one that you
Verzenio?
no. The primary drug that we use for ER suppression
Aromatase inhibitors.
before
Anastrozole,
the very
letrozole,
everybody
tamoxifen?
tamoxifen. Yeah, I
Yes.
took that for 7 years, and then I
Okay.
had a recurrence.
Yes.
and then they ramped it up to the fulvestrant and the Kisqali. Is that a good, in your opinion, is that a good combination? And, you know,
Yeah, so essentially it's a very powerful combination. Fulvestrant is an estrogen receptor downgrader, whereas it's like the next generation to the tamoxifen. It has indications for locally advanced disease or metastatic disease. The drug manufacturer did not develop the drug for early stage breast cancer. So that is why we cannot use it in early stage breast cancer. But kind of from what you're describing, if you were on tamoxifen before and there was a recurrence, that's like a perfect indication for using it. If you have no other evidence of disease, depending on, again, not knowing all your specifics,
yeah.
I'm not sure you want to share all that. But essentially what I do in my practice and what everybody does is that you periodically, if it was locally advanced disease, you will get, certainly blood work and maybe some scans just to make sure that the disease has not spread further. But essentially, it's working if you're not having not experiencing a disease progression, which is a very unsatisfactory answer, I know. But true disease progression typically comes with symptoms, or in kind of chest wall recurrences, we see changes in the chest wall, or distant body disease has symptoms. So depending on kind of where you are in your treatment, and you don't have to say right now, typically patients like this, from what I've gathered from what you're describing, typically get scanned once or twice a year. They get routine blood work, and our hope is that things continue to stay quiet, and that's our measure of success. There are studies looking at circulating tumor DNA as a surrogate measure in the blood to tell us, where we are in terms of microscopic disease status. They're not quite ready for prime time, but lots of exciting disease in terms of, there's a lot of studies looking at minimal residual disease, and can we interrogate the blood to essentially figure out, is there a little bit of disease active right now or not? Do we need to change our therapy based on that microscopic disease presence in the blood, but not quite ready for prime time yet?
Oh, yeah, that's Signatera and Gallery,
Yeah,
right?
that's one of them, but there's a bunch of them now.
Oh,
So Signatera is one of the many assays. This whole field of blood-based biomarkers is going to only explode in the next 5 years, and I think it will kind of question a lot of our existing standards of how we respond to disease status. The theory, the dream is, if we can find a disease when it's microscopic before it's overt disease in the body, perhaps we have a better chance of eradicating it altogether. So a lot of intervention studies are asking that question. We don't have the data to show that it indeed does that, but that is the leading hypothesis.
okay. Thank you. Oh, one more statement here is that when you said, somebody mentioned about getting us to be involved in studies or to be informed about things, that what you commented on, I wouldn't have a clue unless I saw your thing here about being available to go into studies and whatnot, because I'm concerned about recurrence. I mean,
That's
obviously.
one of the things that I do. I will keep in touch, and that's why I mentioned it to Dr. Lustberg. Anybody that we do work with, the people that have an interest in the studies of breast cancer in men, I am working with them to get us the information for the clinical trials, and I will then be sharing it with you. I'm trying to make it a little bit easier because I know there's a gazillion trials out there, but very few that are specific to you. And the doctors, as you can see, are more than happy to help with that. So I'm happy to share it.
Okay, one more quickie. I swim up to 3/4 of a mile and I get chest wall pain. Is that maybe from the radiation and surgical scar tissue, or
Yeah.
I just want to make sure that's not like a cancer thing that I should be really going. I'm pretty new in it. It's like 4 or 5 months into my Kisqali and fulvestrant.
Yes. So most likely it's fibrosis and scarring, and these nerve endings have been traumatized by the treatments that you receive. So swimming and stretching and even dedicated physical therapy can be one of the best things that you can do. You may find that if you take a little break, things stiffen up even more. So the more you move, the better. However, if there's been a change, this is how I describe it to my patient. If it's always been like this since you finished treatment, then likely treatment. If there's a change or if things are escalating, not being afraid to bring it up, and it can be easily put to test, to rest with like a chest scan, just to make sure so that you know what your new baseline is and that you're not left wondering. So depending on kind of what the trajectory has done, sounds like it's most likely scar tissue.
Okay, thank you everybody for everything. Thank you. Oh.
Richard, did you have a question?
Actually gonna jump in on the previous one, but then pickle juice came up. And I'll say that with the running community uses pickle juice all the time. You see it at aid stations, at marathons, and things
Yes.
like that a lot. So
Yes.
pickle juice is a good one. Or
Yes.
even just the pickle itself is good
Yes.
too.
Yeah.
Yes, the
Um,
fasting community, people who do intermittent fasting also use pickle juice.
Oh
Yes.
yeah,
Yeah.
okay.
I had met a stage 4 gentleman out in Colorado, and when I went to see him, he actually said he was the one who first told me about pickle juice, and he also said that when they changed their sheets, they put a bar soap, can be any kind of bar soap, at the foot of the bed in between the mattress and the fitted sheet, and for some reason, whatever comes out of that helps him. So there, you're going to hear all these things, but like again, what works for one might not work for another, but it's worth a try sometimes.
Yeah. So the other thing I was gonna say was, so I was on the Ethan trial, and I got the kitchen sink of treatment, which was an aromatase inhibitor, which was an anastrozole. I got a gonadal suppression, which was Degarelix injections in my belly, and I was on Verzenio. So, and I had various different side effects and that sort of thing. Hot flashes being one of them, fatigue, loss of endurance. I can't, if you couldn't tell, I'm a runner, so I was with a lot with reduction in red blood count and also essentially zero testosterone. My endurance went in the tank. But anyway, so I finished. I'm looking at the calendar now. I finished my active treatment on that on the 24th of June, so about 6 weeks ago. And then I had surgery on the 30th of June, so about 5 weeks ago. So I haven't had any active medication other than whatever Degarelix is still in my body. Um, my hot flashes got worse after I stopped. And I'm wondering if that could be because, like, I'm starting to get testosterone back and I have this hormonal flux going on, and that's my body's just reacting to the
Yeah.
changes.
Yeah, so I hear that a lot actually. So I think that is I think kind of as these hormones are shifting, sometimes your body was sort of used to a certain level of things, and as things are shifting, the other piece of it is just the cumulative effect of more time passing on the gonadal suppression that can also kind of be contributing. Um, so Yes, so if it's bothersome enough, kind of exploring option for the vasomotor symptoms is typically, but you're not alone. I have definitely heard that. We don't fully understand exactly what's happening, but our best voodoo explanation is that kind of these hormones shifting can definitely kind of trigger more hot flashes for sure.
I'm just hoping that things will equilibrate and the hot
Yes,
flashes will go away with it.
yes,
But
it's
I've had 2
possible.
whoppers since we've been on the call. That's why I have my tissue.
Oh,
But anyway, I think that was the main thing I wanted to say.
thank you.
Oh, one other thing, as far as the clinical trials go, Sherry was talking about getting the information for the people here, and I think maybe referring to her as an advocate. But the more that we all know on this group, the more we can advocate for those trials too.
Yeah. Yeah.
So the only trial I'm aware of is the one that Dr. Leone offered to me, and I did it. And I was very happy with it. You know,
Yeah.
the
Now, when I was saying me as an advocate, the only reason I want to know, and the main reason why I connect with all these wonderful doctors and why I go to these conferences is so that I can bring all this back to you. This is what I do. This is my job. I'm retired. This is my baby 24 hours a day, because ideal, as you can see, we've got people on here from England, Canada. Boaz has joined us from Zambia. So all of you guys, I consider you like my children, and I take care of you as best I can. So anything that I learn, I will bring back to you and definitely share.
Can I have a raise in my pocket money, please?
When I get a raise in mine. But
Can I
no.
just say, it's been very, very informative, and thank you for the invite. There's been a lot of things that you've been talking about, the fatigue, general loss in strength, and all these sorts of things. But I'm finding it very difficult to try and put these into the bracket of the fact that I've had that cancer operation. Or is it just because I'm getting old at 71? I mean, a lot of these things do happen as one gets older.
Yes.
And it's very difficult to know whether it's the age side or whether it's anything medication or whatever, because I haven't had any side effects that I'm aware of from tamoxifen. And I started taking mine in the beginning of 2023. And a little bit of tiredness is creeping in, yeah. Loss, well, that's been going on for a few years now. But it's very difficult to know which side you can point at. Is it anything to do with the treatment, or is it just the fact that you're aging? But I would like to say thank you very much indeed to Maryam as well for all your information. And I really am impressed with the amount of research that you've managed to get hold of. And are you working with anybody, either yourself or Sherry, are you working with people in the UK? This information can be shared.
Is it for Sherry or
for you,
for me?
working with any colleagues possibly?
In the UK. So I am collaborating with a breast surgeon, Dr. Tristan Park in Mount Sinai, who has rotating breast surgeons come to the US. And so she is working with a number of UK-based surgeons who are coming to Mount Sinai. One of them is due to arrive this week, and then she will come to Yale and also rotate with us in our survivorship clinic. So a little bit more peripherally, but through my colleague, Dr. Tristan Park, is how we're working a little bit with the Royal Marsden breast surgeons to kind of really look at the global local regional breast cancer needs and how different parts of the world are even making different local regional decisions. Certainly access to drugs can also be different across the globe. There's going to be an editorial series that she will be running out of the cancer journal Cancers, where we're inviting different surgeons, including UK-based surgeons, to kind of comment on the emerging local regional issues. So my extent of collaboration is through my colleague in Mount Sinai, but I am peripherally involved, yes.
Thank you.
And then back to your important point about how it's hard to know, is this normal aging? Is this just passage of time? So yes, it is absolutely difficult. But true, so 80% of patients actually do just fine with tamoxifen. So we focus on the 22%, but I think it's important to also say that there is going to be a group of men who do tolerate these therapies well, and also normalizing that experience, I think, is important. But the way we know the difference, it's not very high tech, but if there's ever a question, is this coming from the drug or is it not coming from the drug? If it's bothersome enough, tamoxifen and many of these drugs have about a 4-week washout period. So we do a hold. If it's meaningful enough for your quality of life, doing a hold for 4 weeks can tell us tease out Like how much of this is just normal aging and normal health, other things, and how much of it is a drug? Doesn't sound like that's what we need to do for your particular case, but for patients where we're not very clear what's causing what, typically drug holds can be used in those settings.
So basically what you're saying is I could stop taking it for a couple of weeks to see if there's any effects from that.
If it's meaningful to you, like if you're doing well and you're like, oh, this doesn't even bother me, then just finish your course and be done with it. But if it's meaningful enough for you to know, sometimes we're on these drugs obviously for 5-10 years and our body is changing. And for some of my patients, it's important for them to know what it would feel like to be off the drug for even a brief period of time. Temporary dose holds, especially in the early stage breast cancer setting, have not been shown to impact outcomes.
Anybody else? No? Well, if for some reason anybody does have any further questions, feel free to email them to me and I will get them to Dr. Lustberg and get you some answers. But in the meantime, I thank you very much for joining us. Dr. Lustberg, thank you very much for your time today. And stay tuned. I'll send this to everybody.
Thank you so much.
Have a wonderful week. Thank you.
Thank you very much.
Bye-bye.
Bye-bye.